Hi everyone, and welcome to this clinical series. Today is Dutch testing, and remember, it's the basics, it's some clinical applications, and it's case studies. I'm Catherine Faumann, one of the co-founders of Nordic Laboratories and DNA Life, and one of the drivers of some of these webinars for all you practitioners out there, so that you can get inspired and feel part of us, and we can feel more part of your life and so on, and really just support each other as well. So you can ask questions in the message, and I will try and answer as much as possible. Some of you can even answer the questions if you know them. Please open up for communicating with each other, really. Graeme is our amazing practitioner and researcher, I would say, up in our Nordic clinic in Stockholm. And he's the front person, as many of you already know, in this clinical series. So, and I have noticed that quite a lot of you like him because more and more people sign up. So actually, Graeme, you have reached our record of sign-ups. You have more sign-ups today than Jeff Bland had.
Wow!
So
I paid a lot of people very well to do that.
So, but just before I pass on the stage to Graeme, I just want to touch on a few things. The warehouse in Holland is going really well. We have doubled our team down there, actually in order to be able to serve you all practitioners better and your patients better. Probably at least within the next 2 months, we will start opening up for new products. When I was down there like a month ago, I actually did a video recording of the whole warehouse out there, and it's like a Pandora's box of amazing supplements, and some of them we will add on to our portfolio. We just need the whole system set up and bin locations for all the products and so on. So, but we are working hard on it. And I'm proud to say that one of the people down there is Oliver Moore, my son, who's 19, but he just wanted to try and do something else than being in Copenhagen in the head office here. So he's very excited. So another thing, so all those in the EU are getting supplied from Holland. The prices are still in pounds, but just tell your patients that there is no customs, or it won't be stopped in customs in the EU, because it will be shipped from Holland to another EU country. So in regards to test kits, we are still shipping test kits out from the UK, and really test kits should not be stopped in any EU country customs. It should just be shipped directly with DHL home to the patient. But for some reason, some customers make up their own rules, either depending on the person who's on charge, on duty that day, or for some other reason. So in order not to make too many delays, also because we realized that patients were getting like an extra bill for quite a lot of money in order to get their test kit, we didn't really want that to happen. So what we are doing now is that we are shipping all EU kits to Copenhagen, and then it's distributed with DHL from Copenhagen. So it's just to say that the test kits are delayed by 1 day. Don't shoot the messenger, don't shoot Nordic, but maybe something with Brexit. Anyway, but we're constantly trying to improve our workflows so that we are as quick as possible, as efficient as possible, and so on. So that was just a little update as to what goes on our side. The next webinar we have with Graeme is on the 22nd of April, and it's organics, the basics, clinical applications, case studies. So we're looking forward to that as well. So remember, I'm recording, and remember to write on the side. I will pass the mic over to you, Graeme.
Okay, perfect. Thank you. I think I've let everyone in so far. All right, I'm just going to start sharing my screen here. I'm just going to start there, get the presentation started. So thanks, Anne-Catherine, and welcome everyone today to the basics of Dutch testing. And that's really all we can manage in this time, because as you all probably know, if you've seen or you've worked through a Dutch test, it is one of our more complex tests. It's not always easy to understand. There are many different markers as you flow through page to page. So unfortunately, I can't cover all of those aspects today, but I'm going to certainly cover some of the key points that I felt was important to go over, and strategies and kind of observations that we see here at the clinic in Stockholm, and of course our other clinics throughout Europe. So if you don't know me, of course, my name's Graeme, and my background is really heavily in medical screening and really preventative medicine. Originally from the UK, I'm now living in Stockholm, Sweden, and I'm driving our clinic up here with a team of about 20 individuals now. Variety of doctors, researchers, health coaches, nutritionists, dietitians, and really, yeah, we're using functional medicine and working as a team to, of course, optimize our patient outcomes. And of course, the core of our approach is a functional medicine model. So today, of course, I'm going to cover the Dutch test, how we're using it clinically. So if I can just get into the goal of the session here. So why is Dutch testing helpful, and under what circumstances? What can you learn from a Dutch test? And then key question I get asked quite regularly, things like, well, what's the difference between urine, saliva and blood? And which testing method should I use? And then I'm going to cover some basic result interpretation and treatment strategy options and case study examples. And I'm going to kind of combine those 3 points in the slides as we go. So I'm actually talking through direct examples and what to do as we progress through. So I'm not going to have a set case study at the end. We're going to have markers as we go and what you can do with those. So in regards to the Dutch test, I thought this is a really nice diagram that is produced by them directly, that helps to understand the benefits of using the Dutch test. Of course, it's dried urine test for comprehensive hormones. And as you can see here, it really combines, I mean, the main questions you probably want to know if you want to analyze hormones. You want basic overview, you want the androgen metabolites, we want the daily free cortisol pattern, melatonin. I think this is one of the most fantastic things with the Dutch test that we use very regularly, is looking at the metabolized cortisol along with the free or bioactive cortisol in saliva. Of course, you get the estrogen metabolites, and it's an easy patient collection. And if we compare that to blood, for example, you're only getting very basic hormones. You have to go for a blood draw. Saliva, of course, many of us on this probably have been using saliva way before the Dutch test, and we know there's good points to that. And maybe even some of us have been using 24-hour urine collection, but it's maybe a bit more cumbersome, and you don't get all the information you can get from a Dutch test. So this is where really the Dutch test excels, is that you can get all this information in one simple 24-hour test. So that's why we really like it at Nordic Clinic, and we really like the information that comes out of it and how we can adapt our programs and interventions to deal with the different markers. So when we get into this, one of the common questions we have is that, okay, my patient looks like he or she has adrenal fatigue. I think the first thing to really get across is that there's no really such thing, or there's no such thing as adrenal fatigue. It's more HPA axis dysfunction, and that's where there's been a lot of friction over the years between kind of standard, allopathic medical community and those of you that have been testing in saliva, because of course a blood cortisol check here. This is measuring the total amount of cortisol, whereas if you're using urine or saliva and you're measuring this, what we call bioactive cortisol, so that's what gives us this nice rhythm over the kind of 24-hour period, so to speak. They're measuring different things. So you can have totally normal cortisol in blood, and this is for 99% of patients. They are most likely, if they go for a standard blood test, they're going to have a normal cortisol level, because of course Cushing's or Addison's disease, this kind of cortisol production diseases that can happen, either lack of with Addison's or excess with Cushing's. I mean, these are patients that the reality is that for most of us on this call, we're unlikely to come in contact with those patients. They're normally scooped up very well and effectively by the standard medical systems in your respective country. So you need to understand, when you're using a Dutch test, you've got to look at the graphs, and you've got to be aware that in the graph case here, the first thing is you're measuring bioactive cortisol. So that's cortisol that is not bound to cortisol binding globulin. And when you measure cortisol in the blood, you're just getting total amount. So a lot of common presentations that you might see is that blood is totally normal, like it is here. This is the Swedish spelling. But then there might be a flat line occurring in the diagram. We're going to get into one of these examples later on, but that doesn't mean that there's that they necessarily have a disease present. It just means there's HPA axis dysfunction, and the cortisol that is in the blood, none of it is becoming bioavailable to actually stimulate the various cells. So of course patients have clear symptoms of HPA axis dysfunction, like mental fatigue or physical fatigue, along with many other factors. But again, it's really wording that we need to really get away from this saying that the adrenals are fatigued, because that doesn't happen. We know now from the research that adrenals do not get tired, and it's just there's dysfunction in the HPA axis, where cortisol binding globulin is most likely increased and holding on to all that bioactive cortisol. So of course, if you're looking to diagnose disease like Cushing's or Addison's, so this will mostly be used by endocrinologists. They're going to use something like a blood test, maybe a urine analysis. Of course, most of us in functional medicine, we're interested in, of course, function, and therefore the blood test and maybe the 24-hour urine collection become slightly less interesting, and the Dutch test becomes more promising because we get much better insight into function in general. So that's just a quick note on the validity and best test options. So reality is, with most patients that come to Nordic Clinic, it's very rare where we're going to be taking blood cortisol, because if they got to the clinic okay, or they don't have these extreme symptoms, then there's probably not going to be an issue there with production. Like I said, I've worked in medical screening for 15 years. I think I found one patient in that time where their blood cortisol was at that point where it was, okay, this definitely needs a referral to an endocrinologist for further check. And that's probably many, tens or if not close to 100,000 patients have been screened over that time. So if you're going to use a Dutch test, I'm not going to talk through all of these because the presentation will get very boring. We've got just a few slides here. Why I've included so much text is obviously to help you as a reference point afterwards. So in women, if women have any of these symptoms here, for example, PMS symptoms, cycle abnormalities, low libido, hot flashes, joint pain, fertility problems, a Dutch test is going to be helpful to understanding what's going on, as well as all the rest of the symptoms or maybe diagnoses on here. In men, the list is slightly shorter, but we'll come to the next slide in a minute where it talks about how the Dutch is beneficial for both sexes. But for men, you're looking for gynecomastia, so as it's called, like man boobs, erectile dysfunction, aggression, prostate health. So again, these are good reasons to do a Dutch test in men. And then in both sexes, lots of joint reasons why you might want to run the test, to look for reasons of excess belly fat, so visceral fat deposition, low muscle mass, acne, low energy, fatigue, thyroid dysfunction, maybe things like PTSD or sleep apnea or psychological burnout. These are all reasons why you could clinically justify running a Dutch test, because of course the different hormones involved can contribute to these conditions, or these conditions can contribute to abnormality or dysfunction in those hormones. Now, as you know, I always like to talk through red flags. So if you are not a doctor and a patient or client, whatever you call them, comes into your clinic or your practice, again, whatever you call it, and has any of these symptoms and hasn't seen their doctor, then I would say, of course, it's really important you refer them back to their doctor. That doesn't mean you don't run the Dutch test, but of course, you could have a patient that has some really nasty underlying disease and you're thinking it's a functional problem, and actually they need, pretty quickly, they need some kind of medical intervention and analysis. So just be aware of these main symptoms. Always ask your patient or client these type of questions. So one of the things that we notice, things like IBS symptoms that are just non-resolving or improving. So again, we're going to refer them for gynecological evaluation to check there's no red flags there. So just make sure you always make a note of these things, ask your client those questions. If they have any of those, refer them to their GP for help and further evaluation, whilst you can at that time continue on with your work on lifestyle and function. So when to run the Dutch test? Now there's a number of different Dutch tests, and which one you pick is somewhat important, because there can be some errors in your choice that may or may mean that the client doesn't get most out of the test. So usually if females are on birth control pills, so with the Dutch adrenal, that is probably the best option. You can, of course, you can still run a Dutch Plus or a Dutch Complete, but if they're taking like the oral pill, then it will affect the hormone levels. So you won't get a valid overview of what's going on there. But of course, if you run the Dutch adrenal test only, then you're not going to get things like the organic acids. You're not going to get the melatonin level. So you have to weigh those up. But of course, that the sex hormone part of the test, especially of course the estrogen and progesterone, will be affected. So if females are on birth control pills, then consider doing the Dutch adrenal only. If you're not confident in dealing with the larger report and you want to gain more experience, then the Dutch adrenal is a great place to start. And of course, if you only want to test stress hormones, then the Dutch adrenal is a great test. And then, of course, if we're running a Dutch Plus at the clinic or Dutch Complete or cycle mapping with Plus or Complete, and then really the only thing to come out of that test was there was an issue with the adrenal hormones, then of course we probably would only follow up with a Dutch adrenal test, not necessarily repeating the whole Dutch Plus, for example, especially if the client is on a bit of a tight budget. But big benefit with the Dutch adrenal test is you can run it any day. It doesn't need to be done in a certain part of the cycle for women. So the Dutch Plus, now this is usually at Nordic Clinic here in Stockholm. This is our kind of standard go-to test. So I much prefer to run the Dutch Plus if we can over the Dutch Complete, which I'll go into in a bit more detail. It's not that the Dutch Complete is a bad test. I mean, it's exactly the same test. You just don't get what's called the cortisol awakening response if you run the Dutch Complete. And I really want that with most of my clients that I'm seeing day to day. So when you suspect some imbalance in hormones, sex hormones, stress hormones, all these kind of things, then the Dutch Plus is a great test to start with. You're going to see, of course, estrogen metabolites and biotransformation of the estrogen metabolites. You're going to see androgen metabolites. You're going to get organic acid markers. You're going to get melatonin. But for cycling women, so the problem or the bigger challenge with this test is that for cycling women that have menstruation, it needs to be done on day 19 to 21 of the menstrual cycle. And that's because we're trying to catch the progesterone peak in the test. So it can be tricky for some patients to do it on that day. And this is always a good question to ask your clients or patients when you're getting the test result. And if the progesterone level looks really low, just qualify, did they manage to catch it in the day 19 to 21 window? And do they have normal kind of average 28-day cycle? Because it may not be that the progesterone is actually low. It may just be that they took it on the wrong day. They were a bit late or a bit early. So you've got to bear that in mind. As we always say at Nordic Labs, the quality of the results is hugely dependent on the client or patient doing and performing the test correctly. So with the Dutch Plus, here's all the markers you'll get. I've written here at the top, and I really like it because you get this thing called the cortisol awakening response, or CAR for short, CAR. And the difference with this is that you do a waking sample, then you have 30 and a 60-minute sample compared to the Dutch Complete, which is urine at waking and then 2 hours later. Now, the cortisol awakening response, or this first hour, has really been, or there's been more and more research regarding that and the HPA axis function. And basically, if there's an abnormal cortisol awakening response, then it's telling us that the HPA axis is not responding correctly when faced with a stressor, obviously of getting up and getting out of bed for the day. So this kind of first morning stress test of just getting ready for the day, it's a really good indication of how the HPA axis is functioning. And as you can see here in the diagram, we have 3 different types of cortisol awakening response, a really elevated one. We have a low cortisol awakening response. And of course, in the middle, normal. We're looking for the client or the patient to be approximately in the middle of the graph. So what you might find is that some patients, if you do a Dutch Complete, there might be, waking sample is normal. They're testing 2 hours later, and it could be like relatively near the middle here, but you might essentially have a straight line. So you're really not getting this good CAR response, but you're going to miss that if you're not running this specific test, the Dutch Plus, which captures that CAR information. And we'll come on to that a bit more later about why the CAR is helpful. So the Dutch Complete, it's the same as the Dutch Plus, but without the cortisol awakening response. So the Dutch Complete uses only urine, whereas the Dutch Plus, you have saliva and urine. So you may run a Dutch Complete if you've done a Dutch Plus to start with, and the CAR test was totally normal and there's no issues elsewhere. So when you do a follow-up test, you might decide, okay, the patient or client is a bit tight on money, and we're going to save them some money. We don't need to repeat that cortisol awakening response. So you choose the Dutch Complete. And that's normally where I would go for the Dutch Complete over the Dutch Plus, is in that type of scenario. Of course, if funds are very tight and they can only do one, the complete is a bit cheaper, so that might be a better option. But the Dutch Plus isn't that much more expensive, and if they can stretch that far, you're going to get a bit more key piece of data with that cortisol awakening response. Now, there's also something called the Dutch cycle mapping, and it looks like this. You actually get a total overview of estrogen and progesterone over the whole cycle. So this is better to do. And normally what we do at Nordic Clinic is we'll do this cycle mapping and a Dutch Plus. But we'll generally use the cycle mapping when again, we have a cycling female, but they have no menses, or there's fertility problems, things like hormonal migraines. So especially if there's symptoms coming at certain parts of the month, then this is a really nice test to see what's going on. You can see here, we've got, the estrogen peaks very early in the cycle, as is the progesterone here. So that gives you a bit more detailed input as to what's going on during the whole of the month. So yeah, if you're not sure when to test, so again, these females that don't have a regular cycle, something going on there, then the cycle mapping is an easy one to go to, rather than trying to use an ovulation predictor kit and then trying to catch the ovulation and then doing something like the Dutch Plus, 5 days later or so. So yeah, really nice test option here. If you want to go a bit further, you can go with the Dutch cycle mapping. So the Dutch CAR, basically it's very helpful in these type of situations. So we can see abnormalities or dysfunction with that cortisol awakening response in these conditions that I've written down here. So things like PTSD, sleep apnea, seasonal affective disorder, anticipatory stress. So these are people that, of course, might wake up and they're already extremely stressed about the day, blood sugar dysregulation. So again, this kind of test, it tells you that something is going on, but it doesn't tell you what exactly or what is causing that. So again, that's where you're going to have to put your functional medicine detective hat on, and you're going to have to look through their questionnaire. You're going to have to look through their symptoms. You're going to have to ask more detailed questions to start to draw some conclusions as to why the CAR is abnormal, abnormally depressed, for example, or elevated. So in men, generally, it's a much easier decision. You can do the Dutch Plus or complete or adrenal on any day of the month. So that's much more simpler. Same for postmenopausal women. You can do the test at any time if you're doing a plus or complete. Try and pick as normal day as possible. So some clients will do the test when they're on holiday, and of course you're not going to get a standard overview as to what's really going on. They might be very different in their hormonal presentation during that time. And then also be aware that if patients or clients, if they wake early, so if they normally get up at, let's say, 6:30, 7 o'clock in the morning, and they wake up at 5:30 to go to the toilet, they go back and lie in bed and maybe fall back asleep a little and then get up at their normal time, then you may also see a CAR, cortisol awakening response result that's not valid, because that might have been triggered at 5:30, and therefore you're seeing a very blunted result. So you also always need to ask your client or patient questions around the result, like, was it a normal day? Did you wake up early? Was there a lot of stress that day? Or ask all these questions. Did you follow the instructions? Did you avoid coffee? You need to make sure you cover all those bases. So you're not treating a result that is not accurate because the test wasn't collected correctly. So if the client does wake up early on the day they're supposed to do the test, then normally I would say, skip that day. So again, this is where it gets tight for cycling women, but skip that day, try again for the next day. So I always try them on day 19. If that doesn't go well, then we just do it day 20 regardless. And we take, if they woke up early, we take that into consideration with the results. So what I'm going to do now, we've got some idea of what kind of syndromes, disorders, diseases, symptoms, where the Dutch might be helpful for both men and women. We're going to go through some result interpretation and treatments in some of the most common scenarios. So here we have, as we can see, very, very common result. We have what typically we would term as more of an estrogen dominant type situation. So when you're looking at these test results, if you have a cycling female, so they're premenopausal, then their results should be in this green area here. And then you can easily see the arrow. If it's too high, it's in red. The number, the actual level is stated in the middle of the dial. You've got the postmenopausal range here at the bottom. So very easy to read in regards to the dials themselves. It tells you where they are. So then at the top here, you have the sex hormones. And then at the bottom, we have the adrenal hormones. So we have the total DHEA production here. We have something called the metabolized cortisol. So this you can think of as more the total production and excretion of cortisol. And then here we have the salivary or the bioactive cortisol. You may be familiar with testosterone and bioactive testosterone. So again, we can see presentations whereby patients, of course, can have the right level of cortisol, but they don't have enough bioactive, or they have excessive bioactive cortisol. So this is quite a nice page, and the one that we talk through most with the patient or client. So in this case, we can all see that the estradiol, the main estrogen, so when you have a cycling female, it's the main estrogen. We can see that's elevated. We can see the progesterone is below the normal range. So of course, we're going to ask the standard questions. Did you do the test correctly, day 19 to 21? Just make sure that was all performed exactly to the letter. And if that is true, then we say, okay, compared to normal limits, you're a bit elevated in estrogen. So what I'm going to do is I'm going to start to look at these things. I'm going to go through their lifestyle and confirm there's no endocrine disrupting chemicals, things like bisphenol A. I'm going to ask about pesticide intake, chemicals, cleaners, all that stuff. And I put a link here to an NIH page, which talks more about typical endocrine disrupting chemicals. So normally I give the patient a list of common chemicals and say, look, go home, check all your cupboards and just check the boxes for which ones you have. And then we need to try and remove them out of the home. As the progesterone is low, if this test is correct, then that's what it is, then we can use chaste berry. So that's something that we all have access to in the Nordic system. When the estrogen is high here, what we're going to do is we're going to go further into the report, and we're going to look at how is phase 1 and phase 2 of biotransformation. So even that estrogen's high, is the actual biotransformation process, is that happening efficiently at least? So we'll come on to that later on. Now, if you're a doctor or you work, so at the clinic here in Stockholm, we have an endocrinologist in the team, and we have gynecologists that we refer to regularly. So we could consider progesterone hormone replacement therapy or treatment if that's the right tool for that female. So we always are trying to look at what are the different options here. We're not ruling anything out. We're looking at the medical options, the supplemental options, the lifestyle, nutrition options. We want to try and pick or try and work through a general thought process as to what's going to be best for that client. What do they want? What are they most comfortable with? So we're certainly not ruling things out like a medical intervention. Now, when estrogens are high like this, do they need to increase fiber? So this is a question mark. Go through their food diary. Of course, probably most of you will get that before you see the patient, so you've got some idea of possible fiber intake. And then another one is a common thing to do, address inflammation. So maybe you have some other blood test data with things like CRP or SR or fibrinogen, or maybe even some more advanced markers like cytokines, TNF alpha, interleukin 6, etc. But of course, we can all address inflammation quite easy by just tidying up their nutrition and lifestyle habits. Of course, that's going to be much more powerful if you can get them exercising and sleeping and eating much more effectively than if you're using some kind of supplement, as a single intervention. So just think about those aspects. So here, of course, when I'm looking at these results, that's the main thing that I'm seeing here. We've got more of an estrogen dominant type of situation. We do have a cortisol awakening response that is it's certainly perhaps a little bit higher than I would like to see. There's a lot of bioactive cortisol around. It's not abnormal, but it's high end, and we have high level of metabolized cortisol or borderline high. So we know that this female is producing certainly these higher level of stress hormones. And of course, we could use things like adaptogens, or we could reinforce, make sure you're the common sense things, taking breaks in the day, make sure you're meditating, make sure you're taking walks in nature, make sure you're reading, whatever it is that's going to help to make them more resilient to that, and hopefully lower stress hormones over time. So that would be kind of the main interventions when we're just looking at this result here. Now, other interesting things to note is I generally am looking at these two, so the cortisol and DHEA, because if cortisol, let's say cortisol is here and DHEA is very much more on the low side, then we can say that, or we can view that physiologically more, that this patient is more catabolic. So the tissues are more likely in a breaking down type state when they have that higher cortisol and lower DHEA. So physiologically speaking, of course, you're going to have to try and work on that and improve the DHEA and rebalance that for them to feel generally better. So that's another thing I'm always looking at, what are the levels of metabolized cortisol against the DHEA, as a very rough evaluation of kind of the more catabolic or anabolic type state. Now, with the cortisol hormones, of course, it's a Goldilocks type scenario. We don't want too little, we don't want too much. It's getting it right for that patient. And of course, patients are different, and some results might be high here for this patient, might not have any symptoms of problems there. So of course, you always want to ask, you're not just going to necessarily address the data alone. What are the symptoms that the patient or your client has? So are these results actually a problem for that patient or not? So don't forget, don't overtreat just because of data. You want to always qualify, well, what are the symptoms here? Because people are different. Some people will have higher or lower levels than normal and still function absolutely fine. Now, this is a male result. So you can see there's no progesterone here. So when you get this back, it will look like this. Now, what we have here, of course, you can see is that main estrogen, it's certainly on the low side, but not normally going to be too worried about that in men. But of course, the main thing here being testosterone. Now, what you will find with both some females and males, usually more of Asian descent, they won't secrete testosterone through the urine at high levels. So when you run the Dutch test and you see a testosterone level that's very low, you want to go down and you want to look at the epitestosterone in particular. So if the epitestosterone reflects the testosterone level here, so we've got them here 11.2 and 11.6, then we're going to pretty much know that this patient, it probably has low testosterone, and we need to do a blood test to confirm that. So I always follow up these kind of cases with a blood test. If, for example, the testosterone level here is low, but the epitestosterone is normal, then you probably found one of these patients that they just don't secrete the testosterone into the urine, or they don't metabolize it out that way. So it's not a big deal. It just means that this kind of urine testing for their testosterone levels is not a good way of monitoring that. So in cases like this, I've got a low testosterone, low epitestosterone. I'm going to run a total testosterone in blood plus bioactive testosterone and probably sex hormone binding globulin as well in a blood analysis. Now, here we have some bit of different info. Well, we've got the low testosterone going on again. It's the same patient, but just basically written down some key points. So if you want to treat this low, if it is a true low testosterone, then you've got some different supplements here like maca or tribulus, zinc that you can use. You're then going to go down into further part of the report, and you're going to look at, is the 5A reductase pathway, is it preferred? And you're going to know this by looking at the fan dial here at the bottom. So if this red is more towards the 5A preference, then we know that the 5A reductase pathway is preferred. If it's a 5 beta preference, then that's usually there's potentially less symptoms regarding that. So we may have all be aware that 5 alpha preference, that can lead to things like male pattern baldness in our gentlemen that come to the clinic and have this tested. So I'm going to look at that. We're going to see if there's more 5 alpha preference. We know there can be more symptoms potentially going on there, but also I'm going to potentially investigate insulin dysregulation. So we could use a continuous glucose monitor. We could do a fasting insulin blood test, or we could do an oral glucose tolerance test as well. So if they have low testosterone symptoms, then they usually, if they have low testosterone symptoms, they have low testosterone, and it's a more 5 beta preference, then they probably will feel that more because it's a less potent androgen. So usually those will be the men who have more significant, mood type issues. Now, it could be if they have low testosterone, it could be a pituitary issue. So you need to ask about things like, traumatic brain injury and head injury. Usually I'm going to test this LH, luteinizing hormone, and sex hormone binding globulin as well, if in this case, because that could point to some kind of hyperthyroid or liver disease if those are out of range, which then I can get the patient to the doctor. And then of course, when they've got low testosterone in men, I mean, you really need to, there's a lot of things to think about here. From sleep, you're going to look at heart rate variability. I mean, obesity, muscle mass. Do they have some kind of chronic disease? All of this will affect their testosterone. So just be aware of all those factors. Now, when we get onto this next example here, we can see in this case we've got, it's a female test. We've got a nice balance between well, or if you like, the estrogen's okay. If this is a more unusual example where the progesterone is a bit higher, but we've got a very low or borderline low testosterone result. Sometimes common in females if they're not, working out, lifting weights. Maybe there's some zinc deficiency going on. Maybe sleep is affected. Certainly, when you see a bit more of a depressed cortisol awakening response like this, then I'm going to start to ask questions around their sleep hygiene. So how is their sleep hygiene? What's their sleep like? Because there's not this kind of nice pointed, sharper response that we want. Now, I think this is one of the real like key elements of this test. These are one of the points that I love, that the metabolized cortisol. So the metabolized cortisol result here in the bottom right, the ability of the liver to metabolize cortisol is dependent on thyroid hormones. So whenever you see a result like this, where saliva cortisol is genuinely okay, but they have low or borderline low or low metabolized cortisol. So anywhere from this kind of, if you break the normal range into quarters, kind of, yeah, maybe even the bottom third or quarter or lower, you're going to start thinking about, okay, there may be an underlying thyroid issue going on here. Because if they are hypothyroid, then of course that's going to slow metabolism down. So you're not going to get the metabolism through the liver of cortisol occurring at a normal rate. So this is telling you here, okay, if you haven't checked this female for thyroid dysfunction, and then you run, your TSH, T3, T3, 3T4, maybe you'll run antibodies as well. You can run a Nordic thyroid panel 1 with reverse T3. This patient, she may need medication, T4 and or T3 or NDT, but also look at eating disorder history, because if the metabolized cortisol is very low like this, it can be that the liver enzymes have become damaged, and that's usually mostly because there's some kind of eating disorder history. So ask those kind of questions. All right, so in this case, we have nice estrogen progesterone balance, similar result, low in testosterone. We're going to ask about things like sleep. Again, we have quite a low CAR or a low bioactive cortisol level occurring. So definitely thinking that sleep and recovery can be involved. There's some issues going on there. Now, here we have the opposite. We have high metabolized cortisol. So in that case, we're going to think the opposite, possibly hyperthyroidism. So in this case, the patient's taking Levaxine, so T4 medication, 75 milligrams, and it looks like that's a bit too high for that patient. So then we're going to, again, if you're not a doctor or not working with the doctor, you're going to advise that patient to go back to their doctor and try a reduction in the medication and see if they feel better. Of course, they might be over medicated. Now, if they're not taking any thyroid medication, then they are producing a higher level of stress hormones. And one of the strategies, of course, would be to give more stress reducing type activities, maybe even get a blood cortisol test to follow that up. Now, in this case, we have low DHEA, high metabolized and bioactive cortisol. So we know that physiologically speaking, roughly, they're more likely to be catabolic, so in nature. So we want to try and stop that process from happening. So as you can see here, this is a Dutch complete result. We've got very high morning cortisol, so it could be anticipatory stress. So we're going to ask the patient about, what kind of psychological stress do you have going on right now? Is that work or home life? Then we can use temporarily, you've got adaptogenic support. So there's a number of different adaptogens. And some of my favorites are things like Arctic root, so rhodiola. I mean, you've got ashwagandha. Then we also have things like seriphos or phosphatidylserine that may help to lower cortisol. So what I might be using is adaptogens more in the morning, and then seriphos in the evening to try and pull that evening cortisol level down. Now, again, if they've got any dysfunctional rhythm, you might want to use things like full spectrum light exposure in the morning. But of course, you want to consider the root causes. So why is the stress response or the HPA axis so aggravated? What are the root cause or causes? And that's only going to come from you adding or asking more questions and adding more information around this. Now, again, when DHEA production is so low, if they have symptoms of low DHEA, then of course, if you work with a doctor or endocrinologist and they can give DHEA, that might be helpful, but of course that's their decision. Then we do have psychotherapy or CBT interventions. Of course, if there's ongoing stress, trauma, etc., then you may need to refer to another practitioner. Now we have another quite unusual pattern, huge level of metabolized cortisol. So the cortisol is being metabolized out the system so quickly, it barely gives any time for there to be any bioactive cortisol around. So we get this flatline result that historically we would have called adrenal fatigue, which is not correct. It's just dysfunction in the axis. And that's usually seen in obesity. So if you have a very, of course, overweight obese patients or hyperthyroidism patients. So if this patient hasn't been investigated for hyperthyroidism, they absolutely should be as quick as possible. It's not very often where that will come in, into our room, because of course we're more dealing with chronic issues. And often like hyperthyroidism is scooped up more by the standard medical system very, very effectively, but you might see it. So again, here, when you see this low bioactive cortisol, and this could be a problem if you're just running a saliva test, so saliva only, you'll only get this information. You don't get this metabolized cortisol, and you probably might even give adrenal extract, something like Adrenavive. So you're giving that extract to try and boost this up, but there's already a huge amount of cortisol being made and processed through the liver. So that's potentially going to make them worse. That's going to add more problems to the system. So you of course want to use more strategies like adaptogens or again stress management here. So this is where I really like the Dutch test, because it distinguishes between these two different key parameters, which of course saliva by itself doesn't. Now, if we have the opposite of this, we have normal metabolized cortisol, but we have this very low bioactive cortisol going on here. You see it's below the range. Then this is a case where I might use something like cortisol extract to help try and push this up temporarily, along with adaptogens. So again, Arctic roots, one of my favorites. You then of course you need to get into why has this happened. This looks a bit more like a burnout type scenario. What's contributed to that? Certainly I see there's a lot of like maybe high performing athletes or career driven CEOs, management team. This is quite a common response, and this is going to take it can take a long time to get it back to normal. But you can help temporarily with the adrenal extract, and they can use that for quite a long period of time. Although again, really they need to learn their lesson about not pushing too hard. So you need to think about that, because I have had some patients that really supported this very well. They felt so much better so quickly, and they just go back into the old version of themselves and push too hard and never get out of that loop. So a lot of education and coaching around the client or patient in that way is often needed. Now, in regards to this page of the report, we're going through the flow of hormones here. So from pregnenolone, you see DHEA into androstenedione, across to testosterone, into the estrogen. So here we can see the three different types of estrogen: estrone, estradiol, the main one for cycling women. We've got estriol here. And then we're looking at the two different phases, if we just break this down basically. So we've got phase 1 biotransformation here, and then we have phase 2 here, or like methylation. So we can see different presentations that might occur. Now, generally, we need to look at both, of course, and we need to look first of all at phase 2, because you don't want to boost or improve a phase 1 biotransformation process, then for it all to be stuck here, not being very well metabolized out. So always look down in this bottom left first, work on that to start with, and then go back up here. So in this case, if you've got more of a, you want to lower estrogens overall, then I'm more likely to use something like DIM and NAC, where Brocalox, so sulforaphane, is very effective, is actually improving. So you may have normal estrogens here, but what you've got is a situation like this, where, so if we just ignore these estrogens here, we just accept they're normal, where Brocalox is particularly effective is you want to take this 4-hydroxy estrogen metabolites, you want to push more of those down the CYP1A1 protective pathway, because the risk is the more down this CYP1B1 pathway, then we can get DNA damage. And of course, we don't want that from that potent estrogen metabolite. So if all estrogens are normal here, but you've got more going through maybe 16 or 4-hydroxy, Brocalox is the best choice. If you've generally got high estrogens, then DIM is a better choice. Of course, DIM will also help go more through the protective pathway, but it tends to lower estrogens overall, and you might not want to do that. So usually a case like this, where we've got all three are high, I'm probably going to use a combination of these three. I'm going to go DIM, NAC, and Brocalox in this case, because I want to work on multiple things at once. Now, phase 2 here, you see this is low. So if we had that previous combination of high estrogens, a bit of poor phase 1, and we have poor phase 2 here, then I'm going to need to work on phase 2 first, before I then work on phase 1. So then you can use things like magnesium, B6, choline, trimethylglycine. I mean, SAMe, if nothing else really works, but usually you can get some improvement through these, like these standard supplements here: magnesium, B6, and something like betaine or choline. Now you can run the genetic SNPs. So if you do a DNA health or DNA estrogen profile, you'll get more understanding as to why this is so poor. But first start with this, and then if there's problems in phase 1, then go back to that and support it. Now, just as we get into a bit further into the report, you can see melatonin here. You might see a very high level like this. And this is due to most cases they're taking melatonin. So this is why it's so high, because through the first pass of the liver, you're going to get a lot of melatonin going into the urine. So of course you need to ask, are you taking melatonin? Yes. Okay. Well, that totally explains why that's like that. It's nothing to panic about in that case. It's normal. You have this 11-beta hydroxysteroid dehydrogenase here, which tells you in this fan dial. So we've seen these two graphs from the first summary part of the Dutch test, and then we're seeing, are there more cortisol metabolites or cortisone metabolites being made? And I've just put in a bit of information here that basically 11-BHSD1, it converts cortisone to cortisol. So you're going to get more of a presentation like we have here with the fan dial to the right hand side, and that's more regulated by these different factors here. So if you see a very right presentation, and there's, of course, we have all these symptoms of excess cortisol, then you can down regulate that enzyme by using these strategies here that you can access. Then we have, if it's the opposite end, so if basically you have high function of 11-BHSD2, so that's converting cortisol to inactive cortisone. So you're going to see the red fan dial on the other side here. Then you've got these different strategies to also use. Okay. Now, when you come to the melatonin part of the test, this can be quite common because you see very low melatonin. But these are the general strategies that we're going to use at the clinic. We're going to potentially advise to avoid coffee, or at least stop as early in the day as possible. Sorry to all the Swedes and the Finns on the call that drink coffee like water, but that might be the best option. Might need to move the eating window. So if you're, of course, we often do time restricted feeding with clients at the clinic. We might need to move that earlier in the day, maybe something like a 9-5 pattern, or 10-6 rather than a 12-8 eating pattern. No intense exercise after 6 o'clock. We might prescribe melatonin, or if you're in a country where you can buy melatonin supplementation, we do have melatonin in the system as well, so you can use melatonin there. Circadian rhythm retraining, fairly obvious. If you've got very low melatonin, you need to look at sleep hygiene and routines, and maybe bright light exposure very early in the day. May need to just get them more out in nature. Basically living more to the natural rhythms of the day, not working under just total, kind of crappy artificial light. Try and get them outside, break up that day. You want to look for things like sleep apnea or sleep disorders. So you may need to refer them to their doctor for a test, or if you're able to refer them straight for a sleep apnea test, that's something to consider. And then often we will use trackers such as Aura, the Aura Ring, or Fitbit we're not using it diagnostically, but we're just trying to also look at deep and approximate REM sleep cycles and just tracking of patients over time. So we can see, deep sleep might be very low on an Aura Ring. They have low melatonin. We give melatonin, and there's a radical, huge improvement in deep sleep. Of course, then the patient feels so much better and rested and more energized the next day. Now, as we get into the organic acids, I'm not going to go too much into this because we're going to go into that in another day. But of course, methylmalonate, if it's high, you're looking at a B12 deficient situation. Xanthronate and kynurenate, B6. Pyroglutamate, if it's high or low, then there's possibly an issue with glutathione, and you can either give glutathione directly, or you can use something like NAC. Then we have homovanillate, so dopamine metabolite, and then vanomandylate. So these are American words, but these are noradrenaline and adrenaline. And again, this can show you hidden things. So maybe your patient or client actually has quite a good cortisol response, but then they have a low end of range or a low vanomandylate level. So again, there's some issue with adrenaline production, and you would still need to work on their stress response and help to support them in that way. Then the melatonin is detailed here, and then we have this oxidative stress marker. We don't want that high. We don't want DNA damage going on. We know that's linked with a faster rate of aging and things like cancers as well, certain types. And if that's high, then usually we're going to use like high dose vitamin C and other antioxidants. Of course, we're going to try and understand why that's elevated. So what is the patient doing incorrectly in their lifestyle that's contributing to that? Okay, so as we kind of start to tie this to a close. Been a bit of a whirlwind, Dutch introduction, but this is general rule for how to prioritize. So when you have problems in the test, your patient or client has symptoms, usually you want to start at the bottom here. So work on blood sugar, insulin, gut health, eliminate sources of inflammation and infection, then go on to thyroid and adrenal function, then go to sex hormones after. So can you still hear me, Anne-Catherine? Because my headphones just died.
We can still hear you. We can hear
you. So generally speaking, that would be one way to go. But of course, it does depend on symptoms. You may also need to go top-down approach, because of course, if you get a female who has very significant hormonal symptoms, you might have to come in with a medical intervention at the top, as well as working on thyroid and adrenal health and blood sugar and insulin, gut health, etc. But generally speaking, of course, a lot of the lifestyle factors, they're going to influence thyroid, adrenal, and sex hormone function. So when you have just some general dysfunction going on, start here, work upwards, and that might well just resolve the situation without that patient or client needing to go on any unnecessary hormone replacement therapy. But of course, it's a tricky situation. You need to really take into consideration the symptoms, how bad they are, the situation of the patient, what they want, how fast they want results, and then obviously try and pull together an action plan from there. Okay. So that was the whirlwind of Dutch, which is incredibly hard to teach in like 40 minutes. But I hope it gave some pointers, and at least giving some key areas that everyone can use and bear in mind when using a test.
Excellent, Graeme. Thank you very much. And yes, it was a whirlwind, and you did very, very well. And lots of questions came up on the side, and at some stage they were so just coming in, and I was like, I can't even reply. I think not that we just a few questions, but just for the sake of it, because I think some of the questions that came up several times was, and I'm probably going to rephrase, we won't like put the questions in a way like, because of course the concern is, when could you use a Dutch test and it would be wrong? And I think in that question, I'm adding in if someone is on a hormone coil, or if they're on contraceptive pills, would you do something wrong by taking the test, or will you still get information out of doing the test?
Yeah, we have, if you go into the Nordic VMS system, there's an actual diagram if you search for the Dutch test and you go to the Dutch complete, especially, there's an interpretation tool there where it actually goes through where different types of hormone testing are beneficial for the different types of hormonal treatment, because whether it's skin or pellet or oral, cream, whatever the patient is using, there are pros and cons to, of course, which test is going to be most beneficial. So I off the top of my head, I mean, I use that. Yeah, it's a little bit difficult, but I use that graph regularly, and that just helps to explain, okay, which is the Dutch a suitable method, and it actually is for most cases, but of course there will be certain effects. So I'd say that the obvious one, if they're on some kind of estrogen oral pill, then you're not going to estrogen or progesterone. You're not going to get an accurate reflection of the hormone. So I would say that's the key point. If they're taking oral contraceptives, then most likely I would just go for a Dutch adrenal rather than a Dutch plus, or
complete. But use that tool. We have it there. You can download it, and that will explain everything that you need to know, because there may be some values that are over-represented by certain hormone replacement, and some which are under-represented in a Dutch test. So you just need to be aware of the pros and cons.
I will, when we share the slides and your presentation, I will make sure we add that graph or in that mail for you as well, because we will mail out a link to the recording and to the slides and this graph as well, so that you don't need to look too much around for it. So then questions came up like in regards to children. So of course we need enough hormones to be able to look at the sex hormones, and of course everything like reference ranges for hormones for kids is a little bit off. So you need to kind of decide when it's time to look at hormones in a child. So mainly for girls, of course, when their period starts, and for boys also a little bit later in life. So those are considerations there. And then, you listed up something really nice with all the different symptoms, and I would say I would even use the Dutch test for a patient who in my clinic come in and say they feel a little bit hormonal, or I feel a little PMS, or am I in perimenopause? I mean, it can even be like more milder things than that when I would start using it. But as you can also hear from Graeme's presentation in the cases, and a lot of it is also looking into lifestyle and intuition and gut feelings, and how do we sleep and how do we behave and how do we act. So a lot of the conversations that we end up having with the patients when we're going through a Dutch is actually really, really interesting, because we're digging really much into their life and lifestyle and their thoughts and their sometimes spirituality and so on. Because we try and here with this test, we try and put a picture or put some numbers on what is going on in their life, but their life is so complex in order to produce a number. So it becomes a very good conversation with the patient, more than you take this supplement because of this and so on. So that's the interesting part of the Dutch test as well. So I think that's it, because a lot of you were good at answering each other's questions as well. And I think most of you would like to go through this recording again, and maybe look at your own results. Remember that. And also remember, we have also further education on Dutch. There's a 2-day webinar with Graeme Jones that we are offering in VMS as well. So do you want to say something, Graeme, before we finish up?
I mean, it's just the usual that, of course, there are many other ways to work with these these results, and of course I haven't covered everything possible, and you might have other ideas and answers that work very well, but these are, I think, a lot of these strategies that I talked about, they're things that we use very regularly at Nordic Clinic, and they generally are effective. So those are the ones, if I've included it, it's because they're effective, they work, and we've seen like clinical efficacy from those strategies.
Thank you very much. Graeme, as usual, you're mind-blowing. You have so many clinical pearls, and of course, having gone through the Dutch now, where there's some organic acids in that test, that allows us to move into the organic acids next month, when Graeme is ready with the next presentation. So thank you very much, Graeme, and thank you everyone for your activity on during this talk, and for being here, and for wanting to learn more, and for being inquisitive, and thank you for just being you and being interested in functional medicine. See you soon all.